Yes, I will call roll call. Commissioner Dorado,
Here.
Commissioner Christian,
Here.
and Commissioner Chung.
Here.
The second item on the agenda is the meeting minutes of February 16th, 2021.
I move to approve the minutes.
I second the motion.
Right, I'll just quickly check that there's a few people on the public comment line. If you'd like to make comment on this item, please press *3 to raise your hand. This is item 2. Okay, no hands, Commissioner, so I will do a roll call vote. Commissioner Christian,
Yes.
Commissioner Chung,
Yes.
and Commissioner Dorado.
Yes.
Okay, item 3 is the housing conservatorship update, and I believe Dr. Hammer is going to introduce the item, and Dr. Almeida.
Thank you very much, Commissioners. Good afternoon. Good afternoon, Secretary. First, actually, before I introduce our speaker or presenter, I wanted to make sure you all are introduced to Baljit Sangha, who I think joined us on today's call. Baljit is our new Chief Operating Officer for the San Francisco Health Network and comes from us from Alameda Health Systems, where he's been for the last few years since leaving his operations position at ZSFG. So we're really excited to have Baljit back with us and invite him to be in these meetings today because they overlap a lot with what his scope of work will be. So welcome, Baljit. We're so happy to have you back.
And if I may jump in, Commissioners, Baljit is a ray of sunshine, and we're so happy to have him back. And not only is he competent, but he's a very lovely person.
And I'll second that emotion. We're really, really happy to have Baljit back. So.
And I third that.
It's good to meet you.
It's a pleasure. Thanks for having me. I want to say thank you, Hallie and Mark, but I will keep it formal. Dr. Hammer and Secretary Morowitz, thank you so much. And again, great to see you commissioners. I'm just thrilled to be here. So looking forward to being more part of all the great work that's underway.
Great. And now I just want to introduce our presenter for today. When I can, it's a privilege to introduce our great program leads who present to this committee. Angelica Almeida is our Director of Forensics and Justice Involved Behavioral Health, and is presenting to you on programs related to that work. You'll also hear later in the full commission meeting, Dr. Almeida present on the street crisis response team. And just want to really acknowledge the incredible work that Angelica does in her regular job, her day job. What I think of is then in all the extra work that she's picked up in both the COVID response work and in a more sustained ongoing way as a leader in mental health San Francisco. Angelica just embodies the term lean in. When a problem presents itself or a complex issue that we need to work out, I think Angelica has slowly emerged as our go-to person to help us figure out programmatically how we can adjust to better meet the needs of the people we serve and really use our resources wisely in the health department, so in behavioral health. So I'm excited to hear Angelica's presentations this afternoon, and so I'm going to hand it over to her.
Thank you so much, Dr. Hammer, and good afternoon, commissioners. Let me go ahead and share my screen, and I apologize in advance because, as Dr. Hammer noted, I am giving a number of presentations today, so I'm sorry that you have to spend the afternoon with me. But let me successfully share my screen. Okay, here we go. Yeah. The slideshow. Okay, so first I'm going to give an overview on our housing conservatorship program, which of course is a pilot that we're implementing in San Francisco. So just to reorient everyone to the conversation, I just want to note that the housing conservatorship legislation is really designed to support individuals who have both a substance use disorder diagnosis and also a serious mental illness, who have 8 or more 5150s or involuntary psychiatric holds within a 12-month period. So the intention of this legislation is to support individuals who are cycling in and out of crisis, whose mental health symptoms are exacerbated by their substance use leading to crisis, but when they're no longer under the influence of substances, they stabilize, they're able to be offered voluntary services, and they exit a crisis situation, but unfortunately over time are deteriorating, and again, it's more of this revolving door in crisis services. These are also individuals who are incapable of caring for their health and well-being. And despite our best efforts, we're unsuccessful in engaging in voluntary services and can't otherwise be served by existing programs such as assisted outpatient treatment or more traditional LPS conservatorships. As you see, this is certainly not a comprehensive list. There's a number of criteria, some of which I just talked about, but one of the primary criteria is related to the diagnostic presentation and the number of 5150 somebody has. Of course, there's a number of patients' rights protections included in this legislation, including documented offers of voluntary services. As I noted, because somebody has to have 8 5150s starting at their 5th 5150, they receive a notice that they're on their pathway to housing conservatorship. Again, all in an effort to support an individual's rights and also to support treatment providers and having those conversations with individuals about alternatives to conservatorship and how we're better able to support them in the community. So just to give a brief overview of how we got here in the legislation, this was originally passed as Senate Bill 1045 in September of 2018, and then adopted by our Board of Supervisors in June of 2019. There were amendments to the original legislation, and that passed in October of 2019. But during this time, since the initial adoption of the legislation in San Francisco, the Department of Aging Services and the Department of Public Health have been working very closely together to partner with our providers, to provide trainings, to actively engage individuals and outreach those who are on that pathway to housing conservatorship so that we can support them. And it wasn't until June of 2020 that the forms were finalized with the court that would allow us to move forward with the case. And at that time, we were able to start that noticing process that I mentioned, where at the 5th 5150, we would start informing an individual that they were on the pathway to housing conservatorship. So to give a little update about where we are at this point, so just to start with, thus far we've had 1 person conserved, and I could talk a little bit more around some of the challenges that we've experienced, but I also wanted to provide some data in terms of the last 12 months of individuals who are on the pathway and what's happening with those individuals. So, and I recognize there were some questions regarding the presentation that was given to the Board of Supervisors last week, so I can clarify that a little bit. So this is data as of the end of January, in which there were 15 individuals who had 8 or more 5150s. So the data below is really focusing on those individuals who may currently meet criteria for housing conservatorship. Of those individuals, 8 are being served in intensive case management or in the less restrictive assisted outpatient treatment. 3 individuals are linked to outpatient services. While we know for this population there are high rates of individuals experiencing homelessness, I will say that it's been incredibly successful and has benefited this population to have access to shelter-in-place hotels. Psychiatric emergency services has worked really diligently to support individuals in transitioning to those placements, and currently 4 are housed in shelter-in-place sites. While individuals may have 8 or more 5150, some of them may be actively engaged in services, and our role as the Department of Public Health is to support those treatment providers to make sure that there aren't any barriers to individuals accessing the services that they need, to address those barriers, and to make sure that we're able to wrap around an individual and keep them away from the pathway to conservatorship. That being said, there are 7 of those individuals who have been served, that they're on that pathway, and that we may be moving forward. 5 of those cases are very close to moving forward with a petition to the court for temporary conservatorship. And just to clarify some of the differences in the data that was shared in last week's hearing, and those questions were a little bit different, but the 63 number, that the 63 individuals that was shared at last week's hearing was related to individuals who had 5 or more 5150s. So this being a subset of that population. We tend to look at the 5 or more because, again, that's when we start noticing somebody that they're on the pathway to housing conservatorship. And those are individuals who, again, may move forward. And so we really want to do everything we can with early intervention to support them. So want to start paying attention to those individuals before they reach 85150s and they're at this precipice. I also want to highlight, again, as I noted on the last slide, we spent a lot of time in preparation of being able to file petitions, but also it is our ethical and legal responsibility to support individuals in the least restrictive settings, that our team within the Department of Public Health, which has primarily been through assisted outpatient treatment, has been working incredibly diligently to partner with hospitals to outreach individuals. And since this law was, since June, we were able to support 140 individuals in maintaining connection or connecting to voluntary services. And 60 of those individuals no longer meet criteria for housing conservatorship any longer. So we've had some great success in supporting individuals in voluntary services. And that being said, we know that conservatorship is still a very important part of our continuum of care. It, of course, is not the answer for everyone. I want to talk a little bit more about our data, and this is related to from the Housing Conservatorship Working Group, related to data from fiscal year 1920. There's 5 data points that are required through the health code. You'll see the first 3 data points are related to individuals who are under a conservatorship. During fiscal year 1920, we did not have any individuals go through a housing conservatorship. So the data you'll see in the next couple of slides are focused on the data points for 4 and 5. Okay. So looking at evaluation requirement number 4, this is specifically looking at the volume of 5150 or involuntary holds that happened in San Francisco, and better understanding the breakdown of who initiated those 5150s. Just to highlight, through the Housing Conservatorship Working Group, we've partnered with Harder & Company to support gathering this information and analyzing this information. We thought it was very important to partner with a team that has a lot of experience with evaluation and working with complex data sets. And we also thought there was a great added benefit of having an external third-party evaluator to look at this information, because we know that there's a great deal of interest in this. I will say that, of course, this is really complicated information to gather. We've partnered with the local hospitals, and we've partnered with the Hospital Council of Northern California to work on pulling this information. You can imagine, given privacy concerns and limitations in data sets, electronic health records, there's varying levels of details that we have. Of course, data that comes from Zuckerberg San Francisco General Hospital, we know that most information about that population. But what we did is we looked at, and I'll say the CCMS data is the data specific for Zuckerberg San Francisco General. So we have information about the unique number of individuals and the total number of 5150s for that population. Unfortunately, for the other hospitals, we were not able to get patient level data, so we don't know the number of unique individuals that account for the total number of 5150s. So I want to caution that we're looking at this as adding it because obviously there are nuances in that, but that is the best way for us to look at the totality of 5150s during this fiscal year. And what that suggests is that there were roughly 9,000 5150s that occurred during this time. We also partnered with the San Francisco Police Department to better understand their volume of 5150 holds that were initiated by law enforcement, that being a particular focus for the working group to better understand that. And I'll delve into that detail a little bit more. But just to say, given the number of 5150s that they reported initiated, that accounts for roughly 34% of this total 9,000. So this talks a little bit more about the limitations, some of which I just shared, but again, there's likely a large number of duplicates of individuals in this data set, and so we don't have a great sense of the number of people that we're talking about in terms of the volume of 5150s. I also mentioned the complications in terms of electronic health records and the data we're able to pull from that from our different partners. During this time, there's also the migration to Epic. And so while we're not aware of any limitations in the data, we do want to caution that there might be some gaps in data as that migration was occurring. But I'll say from our first year to this year, we've gathered a lot more information. We're hoping to refine this as we're moving through this pilot process. We know that this is incredibly important, not just for housing conservatorship, but also as we're looking at Mental Health San Francisco, how our system is better able to support individuals. And so this will continue to be a primary responsibility of the working group and a goal of us and our partners to ensure that that data is getting refined. So I want to transition to evaluation requirement number 5. And this is specifically looking, as I mentioned, this is a primary focus for the working group and certainly as we see in the health code. But when looking at 5150s that were initiated by a peace officer or by the police department, understanding why it was the police department that was involved, and if and to expand on that, really, if that's the most appropriate person to be involved. I'll say this also ties to the conversation we'll have at the full commission hearing around the street crisis response team. So these conversations really flow together, but I think that this is incredibly valuable information. And again, this is really complicated information to gather and assess. Most electronic health records do not track who initiated the 5150. It's really looking at the assessment of that individual. And so what we decided to do with Harder and Company is to work with the police department to pull a random sample of incident reports where a 5150 was initiated, and Harder delved into those incident reports so that we could better understand the types of calls, the reasons for those calls, and hoping that, again, this is a representative sample, but it's not all of the 5150s that were initiated by law enforcement. I'll say what that turned into is 147 unique reports that were pulled from 28 days, again, randomly across the year, and then looking at more specific information. So this gives just a quick snapshot of what that data told us. But what we can see is that in 84% of cases, the person who called 911 and law enforcement responded for an individual experiencing a behavioral health crisis was a stranger or a friend and family member. Most of these individuals, or 61%, were placed on a 5150 hold for danger to self. Of course, as we know, 5150 holds can be placed for multiple reasons. So you'll see this is a larger number. But when we're looking at the detention reason, and if there's any harm to self or harm to victim, any weapons involved, part of what we were trying to get at in looking at this information is, again, the reason why law enforcement was present, or if law enforcement was needed in these situations. So to better understand, was there any violence or a weapon at the time of the call? Were there any acts of violence which would indicate the need for law enforcement to be present? And ultimately, what we found is that 78% of cases, there were no harm to others during the incident or during the crisis call. And in particular, I would like to note there was one incident that included a firearm, and that also had no harm to others ultimately in the call. And again, this leads to the question of, is law enforcement necessary to respond to these calls? And as you know, we've had many conversations during this last year about what are alternatives to police responding to calls, some of which include behavioral health crisis, some of which don't. So I want to spend a little bit more time talking about the population data. This is something that we've looked at each fiscal year. And again, looking at individuals who have 4 or more 5150s, we're limited to this detailed information for those who are seen at psychiatric emergency services. And this totals 113 individuals. And again, looking at 4 or more, because those are the individuals who are potentially on that pathway to housing conservatorship. So looking at the larger population. But in terms of demographics, what we see is that most individuals are between the ages of 40 and 50, are male, and are white, or African American. I'll talk a little bit more about ethnicity momentarily, but that is something, again, that the Housing Conservatorship Working Group really wants to focus on. There's been understandable concern about how involuntary treatment might disproportionately impact communities of color, and we want to be very mindful about how a law like this is utilized and who it's impacting. In terms of urgent and emergent services, there's an average of 10.4 visits to PES for this population each year. Not all of those are necessarily an involuntary hold, but just want to note this isn't surprising that this population frequently uses crisis services, both emergency department as well as psychiatric emergency services. They have high rates of contact with the criminal justice system and low rates of engagement with ongoing services. So again, this is looking more at the ethnicity breakdown. And so you'll see the blue column is looking at 18-19 data for PES alone for individuals with 4 or more 5150s, in comparing that to the green column that is looking at the 1920 population that we just talked about. We also looked at how this compares to the overall who's seen at psychiatric emergency services during a fiscal year to better understand, again, if communities of color are disproportionately impacted by having higher crisis contacts or more likely to be placed under a conservatorship in comparison. Related to that, of course, it's important that we contextualize this in the San Francisco US Census estimate of who's in San Francisco and how that relates. And we also plugged in orange the incident report sample to again show in terms of demographic information how that sample was representative of the individuals that we're seeing in this population. So just to highlight, of course, unfortunately, this is not surprising and something that we need to continue to focus on, both through housing conservatorship and how this population is impacted, but also as we look at Mental Health San Francisco. And I know, again, we're talking about that more at the full commission hearing today, but looking at how our services address the needs of communities of color and support individuals to access services and to move away from crisis services and or the criminal justice system. And so, again, it is not surprising that unfortunately Black individuals who identify as Black and African American are overrepresented in the sample, both in general at PES and also across fiscal years 18-19 and 19-20 in terms of those who have multiple and frequent 5150s over that fiscal year period. So I'm going to pause for a second because I'm sure there's questions. I know there's a lot of data that we can delve into here. I just want to share that we do have regular working group meetings, and those, of course, are public. This is where information can be found. We also have all our past presentations on here. And of course, if there's any questions from the public, they're welcome to reach out to us at this email. But let me pause for a second.
And commissioners, before we go to your questions and comments, I'm going to check the public comment line just to see, the public line to see if there's any comments. If you're on the line and would like to comment on this item, please press *3 to raise your hand. *3. All right, no hands, commissioners. So please let us know if you have questions or comments. Commissioner Gerardo, and then
go ahead.
Thank you. Thank you. This is a great presentation. I was the one who was submitting questions too. One of my questions as well is on in the data, it was you had 17% or what was it? 17 gravely disabled individuals in the data. What's the disposition and what's the criteria for those that are gravely disabled? I guess I was concerned about that population, the 17%, or I think it was, yes.
Yeah, Commissioner, just to clarify, I think it might have been this slide where we were looking at the reason for 5150 for the sample that came from the police reports for the fiscal year. Is that correct?
No, I think it was another slide, which I'm going to, I had a number. I don't know where I got that, but maybe that was it, the 12%. Yeah.
It's 12% here. Yeah,
Okay,
and just to highlight, unfortunately, we don't have the details of the disposition. All of these individuals went to the hospital and were treated at the hospital. I couldn't tell you details for the
Okay.
specific individuals, if they were placed on a different type of conservatorship or if they were admitted to the hospital.
okay. I understand that. So we're not able to get any further information on them. Okay. But I guess that's my concern about that population particularly, you know, of whether they went to intensive case management, et cetera. But this is not what the purpose of the data is. So thank you.
Yeah, and Commissioner, I will share, of course, individuals who have 8 or more 5150s typically go to the hospital for a number of different reasons. It could be for danger to self at 150 and gravely disabled for another. And just to highlight again the data point, for the individuals we have been successful in engaging in voluntary services, most of those individuals are served at an intensive case management level of care. Some are served in outpatient services or had existing outpatient treatment, but also whenever possible, we're diverting individuals to assisted outpatient treatment, which of course is less restrictive than housing conservatorship.
Do you have the follow-up of course, this is part of your next presentation, on what the compliance rate is for those individuals with the voluntary treatment?
Yeah, so that's something that we are actually tracking very closely. Of course, we know that connecting individuals to services is a first step, but we need to support them in continuing those services. So I'll say that our assisted outpatient treatment team, and as you noted, I'll talk about this more in the next presentation,
Right.
will often spend a number, sometimes months, weeks, bridging individuals into those services to support that engagement. And that varies for each person, but that could be bringing them to appointments, following up with them. We know that particularly for this population, and because we're disproportionately serving individuals of color, that a lot of what's needed is developing that relationship and trust, and that takes time. And so as we're transitioning the individuals to long-term services, that also needs to take time. And so there's often overlap in multiple services before that full transition happens, so that we can ensure that compliance, as you noted, and that engagement over time.
Great, thank you.
Commissioner Chung.
Hi, thank you for the presentations. It kind of brings back some memories when I was first working for the master leasing programs, and back in 2000. So a lot of the kind of structures do remind me of that. And I was curious about a couple of things here. So this is specifically for those who have 8 or more 5150. So it's not a combination of four emergency services and 4 5150 services. Is that correct?
I really appreciate that question. It is 8 or more 5150s. It's very specific to that. And I'll highlight for individuals that we're anticipating being able to move forward with, they will likely have more than 8 5150s in a 12-month period, because the level of detail that needs to be required in each note for 5150, it's a high bar to meet for the documentation to submit to the court. Starting at the third 5150, there has to be a documented offer of voluntary services in each note. And so what we're finding is that sometimes there's limitations in data entry or documentation at the hospital. And so individuals frequently have more than the 8 5150s.
And okay, so the other questions I have is I know that Commissioner Girardo mentioned intensive case management. Actually, that was also my questions as well, because you have Mission, Westside, Community Focus, all these intensive case management services, and how do they play a role in this conservatorship?
Yeah, so in terms of voluntary services, we're of course having conversations with individuals and connecting them to the services and to the providers that they feel most comfortable working with. And so that's accessing our entire continuum of services, ranging from low threshold case management to intensive case management. For individuals who are placed under a housing conservatorship or might be placed under a housing conservatorship, again, this also very closely ties to assisted outpatient treatment. And as we'll talk about in that presentation, we have a dedicated capacity with a full service partnership for that program. And so we're leveraging those resources to support this population to make sure that we're able to access treatment in a timely manner. And to support them. And so we've been effective with that. I will say there's a number of individuals who have existing case managers as we're seeing their data come in and recognizing that they are on this pathway. And as I noted, a lot of the work that we're doing is providing that support to the treatment provider to make sure that they have the resources that they need and that we're helping to break down and address any barriers that they're experiencing and supporting the individual.
Great. It's really exciting to hear that after 20 years, there are more like services to bridge some of the gap that's been in existence for a long time. Thank you.
Of course.
And Commissioner Christian. Commissioner Christian, I see your hand up.
Yeah. Can you hear me?
Yes.
I'm still having some bandwidth issues, Mark, and so I may turn my camera off. Let me know if you can't hear me. So Dr. Almeida, it's really good to see you. It's been a while, and I'm so glad to have this update on this program and your work. And as Dr. Hammer said, I thoroughly know what she means when she talks about the quality of your work and engagement. And so I'm happy to be able to touch base with you again. Looking at the same slide again on page 9 that you were referencing before, I'm wondering, you spoke about the disparities between Black, African American, and other people of color versus white people being pulled into the 5150 situation and perhaps conservatorships. But on page 9, is it possible to disaggregate these numbers, this data, by ethnicity and race? I'm wondering whether we can know how many of the 5% of people whose calls were initiated by a police officer or security director were people of color. Are we able to find that kind of thing out yet?
Commissioner, I do not have access to that information. I could certainly reach out to Harder and Company to see if they would be able to easily pull that and follow up. I'd be happy to do that.
Thank you, because I think that would be useful information to see and to have. For instance, if it seems like most of the calls for people who are disproportionately affected by this are coming from the police, maybe that indicates a couple of things, including maybe we need better community outreach and better touch with the community so that people from the community might be calling more than they would otherwise, and also maybe we need to look at the police and security people to see what might be going on. But I think that would be useful information on a couple of levels.
Yeah. And Commissioner, I'll just add, again, I noted that 84% of calls came from a friend or a stranger in no relation, and the bulk of them from a stranger in no relation. And I know as we're having these conversations as a city, as alternatives to policing, one of the things that we talk about and why a team like the Street Crisis Response Team is needed is that particularly for individuals of color and particularly for Black or African American men, I think that there is the risk of strangers weaponizing 911 and calling 911, even if police are not necessary for that. And so I think having alternatives to police responding is, of course, beneficial for the individual and also for law enforcement, and making sure that it's the right skill set that's going to the scene to address an individual's need, and particularly individuals who are in a crisis moment.
Mm-hmm. I totally agree. And, in addition, and this may be too granular to be captured easily, But if it's possible to have the district stations that these calls are coming from, so that we can see whether there's a concentration in one place or another. And I don't know if this is too granular, but to understand in the community, the neighborhoods or the supervisorial districts that the calls might be coming from, so we can get that level of a picture of what's happening in the community. I could understand that it might be a little granular. I also had a question on slide 4, where you're talking about the implementation of the people who have been conserved and what the process is like. I'm wondering if the 2 bullet points that have the 7 people, 7 are currently experiencing homelessness or housed in SIP hotels, and 7 people have been served and are on the pathway. Are these the same people? That group of 7?
They are not, there may be some overlap, but they are not necessarily one and the same.
Okay. And can you give us just a little more information about the process for the conservatorship, the path of the conservatorship, and once someone is conserved, what goes on with them?
Yeah, absolutely. So again, starting at while we want to try to have early intervention, and again, we're gathering information and we have this level of detail for individuals who are seen at psychiatric emergency services and are also partnering with our other hospitals to identify individuals who might not, where we might not otherwise have that data. But partnering to identify individuals to try to outreach proactively and support them away from that path towards housing conservatorship. But starting at that 5150 is really the point where they start to receive that notice that they are officially on that pathway. They receive that notice at the 5th, 6th, 7th, and at the 8th 5150 is when the treating psychiatrist is able to file a petition with the court to initiate a temporary conservatorship. At that point, under the health code, it is the responsibility of the assisted outpatient care team, which includes, and again, I'll talk more about this momentarily, but it includes both clinicians and also peer health workers who provide both peer support and also family support to outreach individuals 3 times before it is officially granted by the court to try to offer and support individuals in accepting voluntary services, which could include residential treatment, partnering with HSH to support placement at a shelter-in-place hotel or a shelter if an individual is experiencing homelessness, of course, case management, and depending on what an individual's needs are. If we're unsuccessful in diverting individuals away from housing conservatorship, then they are placed on a temporary conservatorship, which can last up to 28 days. Once they're placed on a temporary conservatorship, there is then a permanent conservatorship hearing after that point, after that 28-day period. And I'll just note that a permanent conservatorship is a misnomer. It is not permanent. The conservatorship lasts up to 6 months or until somebody no longer meets criteria. It can be renewed at 6 months, but it is different than an LPS conservatorship that can last up to a year and be renewed on an annual basis. Of course, if somebody is placed on a conservatorship, it is the conservator who's able to consent to treatment on an individual's behalf. The options, of course, would look very similar to what are being offered on a voluntary basis. We, again, are trying to do everything we can to support individuals in the communities where they live and in the least restrictive settings. And so wrapping around an individual to provide that support, which could include regular outreach, obviously meetings with case managers. We really try to take this approach for both this program and assisted outpatient treatment, but this whatever it takes and wherever it takes approach to support individuals. And again, where they feel most comfortable and building those relationships so that we can support them in no longer needing conservatorship and being able to transition to long-term care. Commissioner, I don't know if that completely answers your questions, but please let me know if there's additional details that would be helpful to share.
Thank you, Dr. Almeida. That's great for now. Thank you.
Commissioners, some folks popped up on the public comment line after the fact. I'm not quite sure why it took them afterwards, but Commissioner Gerardo, is it okay if we honor that? All right. And so if you're listening and watching but not able to talk, then you're on the public comment line. And so please press *3 if you'd like to have your hand raised so that we can recognize you for public comment. Jessica, that would be you. So press *3 now so we can honor the fact that you were trying to make comment. I'm going to unmute you one by one so that you can make comment. You've got 2 minutes. Okay, here we go. Please let us know that you're there.
Hello, my name is Rhea Small. I'm an organizer at Senior and Disability Action. Can you hear me?
Yes.
Okay, great. Yeah, I'm calling to read a comment from one of our members who is very concerned about conservatorship being used as a solution to homelessness and people's needs for voluntary mental health services. Hello, everyone. I know the focus of this meeting will be on conservatorship. I just want to bring everyone's attention while you're trying to get people conserved, you really should focus on getting them housing and a nice place to live. We always seem to want to take people's rights away and make it seem like the experts know what's best for them. But the truth is, you need to focus on trying to help people instead of stripping them of their rights and dignity as a person. It's hard enough to survive out here or the help you need to get through the night or the next day. We talk about conservatorship a lot. The word has been thrown around a lot too loosely, if you ask me. Let's focus on changing the system, helping people get back on their feet so they can be productive again in society. I'll say it again, don't strip them of their dignity and self-respect by taking their rights away. Give them the help they need to strive and survive. Sincerely, Elizabeth Grigsby. All right, thank you.
Thank you. All right, caller, I just unmuted you. Please let us know that you're there.
Hi, this is Jessica Lehman with Senior and Disability Action. Thank you for reopening public comment. We thought it was going to be on SF.gov TV and it wasn't, and then it was hard to find the number. So if there's someone I can follow up with about that, I think we had other folks that were trying to join who couldn't. But I really want to express appreciation for Angelica Almeida and for the commissioners for the excellent conversation about this, which, to be honest, feels very different from some of the past conversations where I think there's been political pressure around getting people off our streets. And I think Angelica referred to that, right, is that 911 can be used as a tool against people who are on the streets and who don't have a lot of options. And so here I feel like it's been a much more open conversation and acknowledging the trauma that is caused throughout the system of 5150s and conservatorship and a lot of the other issues. So thank you for that. And I just want to reiterate that it's nearly impossible for someone to get out of crisis when they don't have housing. And that I know it's not something you all can do directly, but I think to keep pushing that if we really want to help people, we have to make sure there's more supportive housing available, and that has to be available earlier, right? Waiting until someone has reached 85150s before we offer them housing, or to say that someone has refused voluntary services when there hasn't been housing attached to it just isn't the whole story. And that we know that many people who get a 5150 and go to psych emergency services don't get referred to coordinated entry, and of those who do, many of them don't actually get into housing. We're also really concerned with the data that you just saw, that nearly a third of people with 4 or more 5150 are African. And I don't think anyone knows exactly why that is. You know, I think we understand why a lot of the systemic racism ways, but we can't keep on going with a program that is racially unjust. As far as alternatives to police, it's exciting that there's a great community effort.
I'm sorry, that's time. Everyone has 2 minutes. Thank you so much.
Oh, thank you very much.
Okay, sure. Okay, Mr. Cooper, I am unmuting you. Please let us know that you're there.
Thank you. Yeah, I'm Alan Cooper. I'm a physician. I've had retired largely, but I've had some training in substance abuse. I have a question and a comment. My question is, these people have been evaluated, and I've been curious about this right along and never gotten an answer, 8 times. Why were they always released? And has anybody looked at the notes to see why the examining physician on 8 occasions didn't think they needed further conservatorship, like a 5250? And my comment is, and a suggestion, the data in the literature about the utility of coerced treatment or directed treatment against someone's will. And the long-term outcome is really quite poor, and the conclusion that it works certainly doesn't work as well as voluntary treatment. And whether it works better than nothing or not, I think it's fair to say it's not established. Hopefully you will, if you continue with this program, do not only short-term follow-up, because short-term when somebody's in coerced treatment, they'll do fine, the same as if they're in voluntary treatment, because they know it's the only way they can get out. But whether you will be able to follow up and get long-term data and on this, which can become a very valuable cohort. So that's my question and my comment.
Thank you very much. All right, thank you, commissioners. Shall we move on to the next item, Commissioner Dorado? Okay. Item 4 is assisted outpatient treatment.
Okay, so let me transition to talking about assisted outpatient treatment. And again, it's always exciting. We launched this program in 2015, and so to be back every year to talk about it, and I'll just say, I think I've shared this before, but assisted outpatient treatment is something that's very near and dear to me. It's how I first came to the Department of Public Health and overseeing this implementation, and I am incredibly proud of the work that this team has done and the successes that they've seen. So always very much grateful to be able to talk about it. So just to say again, to reorient us to this conversation, this legislation is commonly referred to as Laura's Law. It's unique that, and I'll say this is changing, but at this current time must be adopted by a county. As of July, counties will need to adopt assisted outpatient treatment unless they otherwise opt out, which is a big shift, but also very exciting because again, we've seen this as an incredibly effective tool in our toolkit. What it allows for, though, is for individuals who have a serious mental illness, who are deteriorating and were not successful in engaging in voluntary services, to be able to move towards court ordering an individual into outpatient services. It is different than conservatorship and less restrictive in that it does not allow for forced treatment or forced medication, but it's really designed to leverage the black robe effect as the symbolic weight of the court to support individuals to accept ongoing and voluntary services. With, of course, a goal of reducing hospitalization, incarceration, and victimization. In San Francisco, of course, when we were looking at implementing this, this was the first kind of program here, and we wanted to make sure that we were able to implement a program that was both dynamic and flexible to meet the needs of individuals. So it is very much community-based, mobile, and multidisciplinary team that spends most of their time in the field supporting individuals. It is absolutely focused and at every step in this process based in principles of recovery and wellness, trauma-informed care, and client-centered, with multiple opportunities for individuals to engage in voluntary services before we pursue a court petition. And you'll find that it really is rare that we get to a court process for individuals. But as I just talked about in the housing conservatorship presentation, and certainly is true here, and that has informed our housing conservatorship implementation process, is that we really employ a whatever it takes and wherever it takes approach to support individuals. Our team meets with individuals in the community, in alleyways, in the hospital, in their homes, really wherever they feel comfortable. There's two parts of our program. There's a DPH side of it, and then as I alluded to earlier, we also partner with UCSF Department of Psychiatry at Citywide to provide a full service partnership for this population. So in terms of the DPH care team, that includes a program manager that is a psychiatrist, a team of clinicians, and then also team members that provide both peer and family support. I want to highlight something that's unique to assisted outpatient treatment is that one, our program provides family support to individuals in a very intentional way, but also family members are able to refer individuals to the program, which is unique. In terms of our partnership with UCSF Citywide, again, they are primarily responsible for providing a full service partnership level of intensive case management to individuals who are served under a court order. But again, because it's very rare that we end up initiating a court order for individuals, they also work with individuals who accept voluntary services. Having this team dedicated to AOT provides us with that flexibility so that we can immediately connect people to services when they're amenable to treatment. And their team includes, of course, supervisors, case managers, psychiatry, et cetera. So just to highlight, the DPH team is responsible for providing education to the community about this program, for receiving referrals for individuals and triaging their appropriateness for the program. They also do a lot of work in that initial engagement and outreach to individuals. And then ultimately, if a court order is needed, they are the ones who submit the court order requests, provide expert testimony to the court, and provide ongoing updates to the court. Whereas the Citywide team provides the ongoing treatment services to individuals. So just to highlight that referral sources are outlined in the legislation. This includes treatment providers and family members. We find that most referrals come from treatment providers and family members. And then there's a unique, as I mentioned, aspect of the program to focus on family support. Recently, the Citywide team, which also includes peer support, as well as the DPH team, launched a family-to-family support group for family members. So just to delve into the data for this population, so this is looking at individuals who are served in fiscal year 1920. So in total, 95 referrals were received by the program. And again, there's strict eligibility for the program, including that individuals have to have 2 or more inpatient psychiatric hospitalizations or jail contacts where they received psychiatric care. While this is different than a conservatorship, it can potentially lead to a court order. And so there's a number of criteria that we need to assess to determine a person's appropriateness. But when we're looking at the demographic breakdown for the individuals who are served, which was a total of 78 individuals during this fiscal year, most 52% identified as male, were roughly between the ages of 36 to 45. And I just want to highlight in comparison to housing conservatorship, this is a slightly younger group than those we see who are on the pathway to housing conservatorship. But similarly to that population, most identify as either African American or white. So not surprising, given the nature of who this program is intended to serve, these individuals disproportionately show high levels of contact with psychiatric emergency services, psychiatric hospitalization, and I apologize, I'm just noticing that spelling error there, incarceration, and individuals experiencing homelessness. But when we look at outcomes for this population, again, we have been wildly successful in both supporting individuals and accepting voluntary services and successfully connecting them to care. During this fiscal year, we were able to connect 51% of individuals to intensive case management. Only 3 individuals were treated under a court order. Specifically looking at the outcomes for citywide case management, because again, there are situations where somebody had an existing provider where we supported that reconnection or were better served by a different provider. But looking at that dedicated capacity within citywide case management, we saw significant reductions in negative outcomes. And this, again, is just in this fiscal year. And that includes a 9% reduction in psychiatric emergency contacts, a 24% reduction in psychiatric hospitalizations, and a 49% reduction in jail contacts. A couple of quick things I want to highlight. Again, this program launched in 2015, but after 3 years, we did a really deep dive into the program and looking at long-term outcomes. And what we found is that while we have immediate positive outcomes for individuals, that those are sustained over time, and that overall there are statistically significant reductions in these negative outcomes that I talked about, including crisis contacts, hospitalizations, and jail contacts, which again, looking at the overall success and long-term success of this program and this kind of intervention for individuals. I also want to talk a little bit specifically for this program, the impact of COVID on these outcomes. And so we know, of course, that 2020 brought a number of unique challenges. And I'll just say, while this team tends to work with individuals for a longer period of time to develop those relationships and support individuals in accepting voluntary services, we've seen that become an even longer period during COVID. With the dramatic shift in the shelter-in-place order, we suddenly had a much more difficult time locating individuals, and this team is incredibly skilled at finding individuals. But there were a lot of shifting and moving pieces, including that we weren't any longer able to see individuals at the hospital. And while we're now able to do that over Zoom, we know that there are limitations in that in terms of the quality of that connection. Also, individuals might not be willing to meet over Zoom, and it's not the same as being able to outreach an individual. And so while we still have had a lot of great successes, we have struggled with being able to locate new referrals into the program, although we continue to work really diligently to do that and mitigate those challenges. Again, I also noted that we are working with individuals for a longer period of time to support that stabilization and connection to services. The other thing I would like to note in terms of the hospitalizations, just to say, while we see that individuals have fewer hospitalizations, and this is seen again in previous years, not just during this last fiscal year, those hospitalizations tend to be longer initially when working with this program. And really what we're finding is that the AOT team, both on the citywide and DPH side, does an amazing job in advocating and partnering with the hospital, providing background information in a really comprehensive way, and holding an individual story and their history to support that stabilization and a really strong treatment plan for discharge. And we have found that that's been really successful. So while initially that may look like a negative outcome, what we're seeing is that that's having a really positive long-term impact for individuals who are served by this program. So again, I'm happy to answer questions about it. It's always wonderful to talk about AOT. For individuals who want to know more information about the program, we have our AOT email address here and also a general line that is checked regularly by our DPH team. We also have a website that has more information about this program, including a fact sheet, ways to refer to the program, and also resources in the community. So let me pause there.
Thank you. I will check the public comment line before we move on to commissioner comments. Folks on the line, please press *3 if you would like to raise your hand to speak. Again, *3. All right, I will unmute you, Dr. Cooper. And you've got 2 minutes, Dr. Cooper.
Great. This is just a follow-up for what I said before. It's very gratifying to see how well the AOT people do over the long term because it was voluntary. And I hope before you conclude that housing conservatorship is a success, because you will see a success over the short term, you're taking them off the street, that you have comparable data, because that program is a pilot and other cities are going to pick up on it. And if you proclaim it's a success, because if you have someone conserved, they're off the street, without getting good long-term data, that would not be a service. This data supports AOT, particularly for volunteers, and goes along with the rest of the literature. Thank you.
Thank you. Anyone else, please press *3. All right, commissioners, that is all we have. I see Commissioner Dorado's hand.
Thank you again for your presentation, and it's great news going forward as we're trying to make a dent in our city. I have 2 questions. My first one is there data do you have data on the number of individuals who cycle through AOS?
Yeah, through AOT. Again, in this fiscal year, there were 95 referrals for 78 individuals. So sometimes individuals, and that could be because individuals didn't initially meet criteria for the program, and we support a referral source to identify what would trigger a referral. But we have had some individuals who have cycled through a number of times over the years. And I don't have that exact number, but I will say it's a relatively small population that ends up cycling through.
That's great. It's just, I'm always curious to see who will comply with the treatment and then leave and they're back on the caseload again. My second question is, even though it's just starting, how does the street crisis team integrate with AOT?
Yeah, so the street crisis response team, and again, I'll talk about this more at the 4 o'clock meeting, of course, but I'll just say they are not directly referring to assisted outpatient treatment, but we do have dedicated capacity through the Office of Coordinated Care, and those clinicians will be able to do similar work in terms of outreach and engaging individuals and supporting linkage to voluntary services. But if an individual meets the criteria for AOT, they would also be able to support referring to that program. So they've already, I'll just say those clinicians for the Office of Coordinated Care just started last week, and they've already done outreach with the assisted outpatient treatment team. So better understanding this program when a referral is appropriate and understanding the kind of work that they do.
That's perfect. I mean, that's wonderful. And I'm hoping that as this rolls out, maybe at the end of this year or later in the fall, if maybe you could come back shortly to our committee here and give us an update on the integration of the street crisis team and AOT, et cetera, as we're going forward with OCC, just to see. I guess I'm always most interested in how all of the programs are integrating, and rather than being in separate silos, and that's what you're talking about, is how the integration, and it's just starting. So it's just all preliminary. I totally understand that, but I think our committee would be very interested in the progress of and the integration going forward.
And Commissioner, I appreciate that. Of course, I'm always happy to come back to give updates. And I'll just highlight, while that's something we certainly strive for within behavioral health services, and of course is one of the intentions of reducing any silos through Mental Health San Francisco, it is also something that we've intentionally done in that all these teams, and of course why I'm giving all these presentations today, is that these all report to me, so that we can make sure that we're reducing any risk of silos occurring.
Thank you. I appreciate it.
Commissioner Chung.
Thank you, Mark, and thank you, Dr. Mida, for your presentations on this. And I think that I mentioned that before, is like one of the things that we don't get to really hear a lot about is, like the success stories, especially, like how life is really being transformed because of these services. So I'm hoping that the next time when you bring some of these data back, you can also share some of these stories with us.
Absolutely, and I appreciate that, and we certainly have many, which is a great problem to have. And it's been a while since I've directly worked on this program seeing clients, but I can certainly share that during my time we had a number of cases where we were able to preserve an individual's housing who were at risk of eviction. We had some individuals who had years of experiencing homelessness that were able to obtain housing, reconnect with family members. And I know that work has continued under the supervision of Dr. Wright. And so we have lots of great stories to share, and I'd be happy to do that.
Thank you, Commissioner. Commissioner Christian.
Thank you, Mr. Morwitz. Dr. Almeida, I just want to thank you for the work that you're doing. It is at the nexus of so much that needs to be done to change what's going on in our cities, not only in San Francisco, but across the country. And you're doing a great job, so thank you so much. And I'm looking forward to future reports and engagement.
Thank you, Commissioner.
All right, commissioners, and those online from the public. Item 5 is emerging issues. Any comments from you, commissioners, or any public comment on this item? Please press *3. Emerging issues. All right, I see no hands and no from anybody. So we can move on to item 6, which is public comment. This item is general public comment, which means you can comment, folks on the line, you can comment on anything that's not on the agenda. So a topic that's not listed on the agenda already. Press *3. All right, I'm not seeing any hands. So commissioners, you can consider a vote for adjournment.
I so move.
Second.
All right, jinx on a coat. I will do a roll call vote. Commissioner Chung,
Yes.
Commissioner Christian,
Yes.
and Commissioner Gerardo.
Yes.
All right, this meeting is adjourned. Thank you so much, everyone.
See you at 4.
See you shortly.